Hi, for the show, I don't know me. My name is Francis. I'm one of the volunteers, and I'm doing the teleconference today. So we're starting the ReGU block, and so this conference will be for that. So ring, you're in CCT, red phone rings, and find out that a 27-year-old motorcyclist was struck. Tell you that he's oriented. He asks for information they don't know, and they say that they're about 5 minutes out. So you start getting everything ready, and 30 seconds later, you roll in. 27-year-old elderly motorcyclist, wearing armor, awake and alert. Always in reality, what you'd be doing, obviously, is that you see airway breathing circulation, ID of monitor, vital signs, and looks like a cardiac, but otherwise, relatively unremarkable. So evaluation. This isn't really like a trauma evaluation. So just really quickly, secondary solid case, nothing really that impressive. He was very lucky in this case. Pelvis, you feel it, and what you feel is what this actually is a large open pelvic fracture. Once again, this is not a lean on management of pelvic fractures, but we can talk about that. So, a couple tips about pelvis. Squeeze it, don't rock it. Do you feel instability? Don't keep doing it. This is not a time for the medical student come and feel what it's like to feel an unstable pelvis. It's going to cause more harm. So in that kind of case, first thing you want to do is bind it. We talked about that in another conference. You can use commercial binders. Otherwise, here you can use a sheet. Make sure you bind it at the greater short anchors, not high one of it. One thing else that you notice is blood in the box. So I have two volunteers. Can I have John and Itamar, since you read already in advance, come on up. Woo! I'll have one of these guys. No, you can do that. So, I just like to introduce you to. Is it working?
Hear you.
So, we served 100 random people in the community, and for questions of what the top 5 indications are for a special grade program.
Who's going to be the judge? Francis, you're the judge?
I'm the judge. So, this is iron phosphate. Survey says, what did I just do?
Who's playing? Who's up there?
Let's go.
Yeah. So this will go to the second year class. We'll continue on for the rest of the week.
Oh yeah, no, you can go out.
So second year class. Another choice for the response is what it is. Survey says. Oh. I downloaded this off the internet. Wait. I'm gonna have to say. No, it's still for second year.
Second year. Yeah.
Especially in the setting of a pelvic fracture or some other others penetrating injury to the GU area. Another second year answer?
Okay. Uh-uh.
Any other choices? One
Uh-uh.
more strike and the first years get to steal. Or an opportunity to steal.
Uh-uh.
We have ecchymosis of the perineum.
Uh-oh.
5, 4, 3, 2, 1. So now the first choice is opportunity to steal. With one choice left. If you have to confer, you're welcome to confer. I'm sorry?
Who's your elected person?
Survey said. Answer was actually
Wait, what did they say? What did they say?
Including me.
A round of applause. So the objectives of this lecture are quickly to go through the indications and contraindications of retrograde urethrogram, outline the steps to perform the actual procedure, and then we'll talk about the importance of hematuria in the setting of pelvic trauma. So there isn't any official definite indication for their but there are some classical things that you learn from the physical findings that the point of it is that essentially if you're concerned about urethral injury, you're worried that you may, if there is any sort of a partial tear or integrity of the injury, but that you're not going to convert a partial tear to a complete tear. So blood in the meatus was mentioned. So not this meatus. Hematuria, like I said, another thing is penile fracture. Oh, I'm sorry. Inability to avoid or pain injury should be another related complication. Hematoma, perineal hematoma, stroke, straddle injuries are very common injuries suspicion for urethral injury. And then the first note, thyroid and prostate. I don't know what thyroid and prostate is. Essentially what thyroid and prostate is. So the relative contraindications for a retrograde urethrogram, I mean, there aren't any real absolute contraindications. In some of the textbooks or resources, they say allergies to radio phase contrast agents, although they in the setting of a situation where you're not sure, you can always pre-medicate the patient and drug or steroids and slowly administer that contrast. One source I read said that an active urinary tract infection is a relative contraindication, but I mean, in the setting of a medical case, you may not know the information and it may not be as important to you. And then just remember other life-threatening injuries, precedents as well. Patient shock, worried about whether I should have a full catheterization. So the tools that you need a full catheter, the large syringe, gastrographic and portable X-ray, It can also be done with fluoroscopy, but here in our hospital, most likely we're going to be doing this. If we're going to do it at all, it's going to be in the trauma bay with the portable X-ray. So preparation, what you want to do is you always want to have a baseline. So you want to set up and shoot a KV first, just so you have a pre-picture. And then while they're setting up the second plate under the patient, you fill the 60 cc syringe with 30 cc contrast. If you want to put a little more, you can dilute a little bit, but you don't really want to dilute it too much so you can get as good a picture of the imaging that you can. What you want to remember is if you use a fully catheter, you'll want to prime the fully catheter so you're not injecting a lot of air when you're actually injecting the dye. So once you have the contrast in the syringe, you want to just prime the filler so you have the contrast sort of at the ready for when you actually do the procedure. And then you want to get sterile because you still want to maintain sterile procedure for this kind of procedure as well. So the retrourethrogram itself, a lot of different, there's basically two different techniques. You can either do with a full catheter, or if you're having difficulty with a full catheter, you can just directly use the syringe itself. It gets the syringe into the renal venous. So in the instance of a full catheter, I've seen results with a lot of different numbers in terms of how large a catheter you use. Some say anywhere from 8 French all the way to a normal size 14, 16 French. Dr. Jain, who was discussing about this case, right, so that she likes to use smaller catheters just for ease of passage, or less discomfort for the patient. But it's a sort of a wide variety. What you want to do is you basically just want to insert the full catheter into the head of venous, just beyond what's called the fossa radicularis. Essentially, you want to get past where the balloon is going to be. And then you want to gently inflate the balloon. You don't need to inflate the balloon up to 5 cc or 10 cc. You want to inflate it just enough so that it remains in the area. And then after that, what you do is you'll basically try to position. You want to position the. I'm not talking about usually in male trauma because typically urethral injuries have more commonly in male patients because of the very anatomy. For females, the urethra is longer, has more potential transfer injury. Just remember though that women injuries as well. So if they have blood at the vaginal detritus, you also should be considering this procedure as well. What you want to do is you want to basically position the penis to be directed laterally on the proximal thigh. In some cases, possible directed more superiorly, just to prevent any extrapolation of the contrast that you inject. But that will just complicate the imaging. You'll have contrast that's all over the field that you won't be able to identify whether or not it's having to do with actual anatomy of the patient or just having the extrapolated contrast. Then you'll inject the contrast slowly. You don't have to blast it in. You want to inject it slowly and steadily over the course of 5 to 10 seconds. And then within the last 5 to 10 cc of contrast, then you want to have the X-ray tech shoot the X-ray. You want to get an AP and then possibly get a lateral as well. Once you're done, make sure you deflate the balloon. And if it's positive, then you want to remove the catheter, obviously, because you're concerned about urethral injury. When you do this procedure, one of the advantages of using the Foley is that potentially you can just continue to advance it into the bladder if the retrograde urethra turns out to be negative. This is the schematic of what the two different techniques look like. So this on the left is with the Foley, and the right is directly with the syringe itself. Just really quickly about the urethral anatomy. The urethra has basically 4 parts to it: the anterior, the posterior urethra. The anterior is comprised of the penile urethra, the bulbar urethra, and then the posterior urethra is the membranous and the static. So and this is again more normal when we see contrast filling through the urethra all into the bladder.
It's really important to make sure that you get either picture. Either this picture or the next picture. Really important to make sure you get contrast back through the valve into the bladder. Because the last thing you want to do is have to do this a second time. So your patient's going to be rather displaced. You should give them morphine first because it's probably, well, definitely pretty painful. And you should inject more than 5 or 10 cc's. It's not going to be enough to fill the whole urethra and get it back into the bladder. But if you don't make it to the bladder, you have to do it again. So
that's what it should look like. This is another picture of normal. this is under fluoroscopy. As you can see, there's description. There's no contrast into the bladder itself. There appears to be some sort of a stricture formation or pain stratification in the proximal urethra.
Another thing Fred said was really important is you gotta hold the Foley in or hold the syringe in and don't let it leak around it or blow out. Because if it gets contrast all over the legs and all over the pelvis, it's just gonna coat the plate and you won't be able to see anything. And so you just won't be able to see it. You gotta really make sure it doesn't blow out, it doesn't get all over the place. It's hard to do.
There's a good chance you'll have to wear lead. You might be in there with the patient.
You definitely have to. It's not like much where you definitely have to be in there.
So as you can see in an abnormal rug, you'll see a flake-like pattern, which is showing stratification with contrast. Another thing to note is, as I was talking about in terms of the steps of the procedure, positioning is important. If you look on the left, the penis is situated inferiorly to the patient, like caudate, and it appears that there's disruption of the proximal urethra. But in that same patient, when the penis is directed more laterally, you can see that there's a partial tear and there's some narrowing, but it actually extends further back. So you want to just make sure the position is correct, so you can make sure you get the best study to truly be able to evaluate the integrity of the urethra. The classic teaching is that if you see these signs, you're not supposed to attempt catheterization because you may convert a partial to a complete tear. A lot of the literature says that one attempt can be made or can be tried, at least gently, but with any sort of resistance that to just stop right there. If you're going to call your urologist down, you don't want to be doing anything that they may just assume that any additional trauma may have been just attributed to you. So you may try it cautiously, but just be very cautious and be very mindful of the fact that you come up on any kind of resistance to stop there. Just another little tips about in terms of the catheterization can cause mild transmitory as well. So if you find blood after the fact, catheterization can cause five RBCs for high heart yield. Sort of other life-threatening injuries take precedence, and then trauma and penetrating trauma are really high risk for lethal injuries. So why may you not want to perform a retrieved? There isn't a whole lot of literature on the pros and cons of techniques and whatnot. So I was looking at a couple interesting studies. One was that it was in a surgical journal that looked at patients that had blunt abdominal trauma with pelvic fracture. Out of 60 patients, 49 had CT imaging. 3 of them had urethrogram and or cystogram performed before the CT imaging, and 26 had these procedures performed after CT imaging. And in the cohort of patients that had the retrograde urethrogram cystogram done first, there were more instances of indeterminate or false negative scans, whereas there were any findings of that sort in the patients that had the CT imaging first and then had the urethrogram and cystogram done after. And the thought was that by having this injection contrast in first, that it made potential diagnosis of diagnosis and treatment for atrial embolization by interventional radiology delayed. So it was thought that any of these kind of should go secondary things or CT imaging or that you want to treat the patient. And then in this urology study in 2014, just looked at the interpretation skills by residents in a tertiary academic center, and urology and radiology residents looked at normal retrograde urethograms and BCUGs. These are in non-traumatic settings, and they basically see normal imaging studies were recommended by about half of the urologists and a little more than half of the radiologists. So these are people who are trained to be seeing and interpreting these things more readily, and they were able to see the normal ones much less interpreting the abnormal ones. So I want to I know we're a little short on time, but I think Dr. Silver made some great points. But is there anyone else that had any experiences or tips or suggestions or thoughts on in terms of performance procedures? I personally have never done one. I'm not sure any other residents have.
something you should do early on. Like, they don't send it to the scanner.
Timing is really important because if they have a pelvic injury, you want to do a retrograde urethrogram before you do the bladder study, right? If they have blood from the anus, you have to figure out where it's coming from. You start more distal and work backwards. So you do your rug first, and then now you have to look up higher. You have to look at either the bladder or the kidneys for your second injury or wherever the blood is coming from. So you need to have it fully in place when you go to the scanner because you have to blow up their bladder with contrast to scan it and then take the contrast out and rescan them again. So you have to have it fully in by the time you get to the scanner.
So just a little bit of a side. So now imagine the same patient, but they don't have a pelvic fracture, there's no blood in the anus. They're evaluated for their traumatic injuries, and eventually you get a urine sample and it shows some hematuria, 25 to 50 red cells. The only urine that has some microscopic hematuria. What does that mean? What's the relevance of finding microscopic hematuria? The hematuria can come in a lot of different gradations. Here, the vitamin samples, you can tell which ones are gross and which ones are not gross hematuria.
A, B, and C.
I can hear A, B, and C are gross. I think I think that D is also gross hematuria. So there's a little bit of variability, as you can see. Where I got this from, A, B, C, and D were all considered gross, and D being so what can hematuria mean? It can mean anywhere from injury anywhere from renal injury, ureteral injury, bladder injury, urethral injury, and then, one resource try to make some sort of a systematic approach in terms of the observation of the urine, sort of correlate to what kind of injury more likely to be present. This is one person's thought, but not necessarily dogma, but think urine could be renal injury or bladder contusion. A moderate amount of dark bloody urine, it's extraperitoneal urinary bladder injury, small amount of dark bloody urine, peritoneal bladder injury, and scan your dark blood. Like that, you're never going to be entirely sure it's going to involve sort of more than one. So in terms of looking at microscopic hematuria, 1985, looked at or tried to review 200 patients that had abdominal trauma and hematuria, and this is the kind of intravenous pyelogram. 112 patients that went for intravenous pyelogram and cystograms. 23 patients had positive intravenous pyelograms. Those went through 19 hematuria, more had microscopic hematuria. Patients had microscopic hematuria, which observed serial urinalysis. None of those patients resulted in any sort of complications. And of those 4 that had a microscopic hematuria, it was a positive pyelogram. 3 had abdominal complaints and signs that were concerned about let's get that IVP as well. So their conclusion was that indications for aging are gross hematuria or microscopic hematuria with abdominal signs of fracture. Urological study looking at patients that had, they did try to stratify patients with microscopic hematuria getting imaging versus only gross hematuria imaging. So in an 18-month span, in their first arm, only anyone with microscopic hematuria got imaged. And of those, 240 patients had microscopic hematuria with no bladder injury, 70 patients with gross hematuria with no bladder injury. Second arm, only gross hematuria. 308 of those, and 91 patients with gross hematuria that got imaged had 2 bladder injuries. Based on their assessment, gross hematuria has specifically 100% for bladder injury, and 95%. So going along with that, along with the previous study, that gross hematuria is a much more significant indicator of general urologic injury. microscopic or macroscopic hematuria. 3 cases of those had imaging or not had imaging. The kind of key point to it was that out of this whole study, 54 patients had microscopic hematuria and no imaging, and they had no clinical consequences. And then the 3 patients were required any intervention on these patients. All of them had microscopic hematuria. So they were supporting the routine use of urinalysis in blood trauma. For diagnosis of renal injury, recommendations are gross hematuria or microscopic hematuria instead of hemodynamic instability or shock. Not to the patient are going to get scan anyway, especially in our facility that they're getting much less than that. But it sort of makes sense that the patient will be getting scanned because their last time they're going to picture what is that they're mostly diagnosed or diagnosed. Bladder gross hematuria or pelvic fluid on CAT scan in patients with pelvic fracture, what they're recommending. And then for renal injury infusion criteria, which we sort of discussed earlier, which is dogmatic criteria, but to you what people use to kind of determine whether or not there's concern for renal injury. And you should have increased suspicion with pelvic fracture or strap injury. So in conclusion, we discussed some of the sort of classical indications for respiratory factors, complications. Gross hematuria is more or less an indication for further treatment of the genital urinary tract without any further injury. And microscopic hematuria without symptoms can possibly just be observed and without any necessitating of genital imaging.
Wow, that's good. So good. You're fine.
So the cystogram, just like not a CT cystogram, but the CT cystogram. So a cystogram essentially is like a retrograde urethrogram. The X-ray way would be to, by gravity, instilling 350 to 400 mLs of diluted contrast into the bladder, clamping the catheter, shooting an X-ray, and then draining the bladder and shooting additional X-ray. The CT cystogram is more or less the same way, if I'm not mistaken. Basically, it's still that's a clamping of it's filling of the passive filling of the bladder, clamping the CT scan, and then draining.
It's really important to understand why. When you have AP trauma, it often collapses front to back, and it pops the dome of the bladder. So you have to put contrast in the bladder in order to distend it to let it come out into the peritoneal cavity. But the problem is that not all of them pop peritoneal cavity too. So you may just get a cap of contrast on top of the bladder, but underneath the peritoneum. So it'll just sit there and look like it's part of the bladder until you let the Foley out and then drain it, and then the contrast will drain out of the bladder, but that cap sitting on top of the bladder will remain there. So it's important that you do it twice. So usually what they'll do is they'll fill the bladder with 250 or 350 of 10% contrast, and they'll do your regular belly scan. And then they'll release the Foley and redo just the pelvic. But you have to do it twice in order to see it. You can't do it just once. Give just the pelvic wings down, the top of the bladder down. You don't have to do the whole belly again, but you have to do the bladder.
How long do you need to wait till it's
Just drain the Foley. Drain the Foley, whatever kind of case. Minute, 90 seconds, 2 minutes. You just gotta make sure the Foley's drained out.
So I'm going to try to get Dr. Jain here for some comments. Dr. Jain, can you hear me? You're muted. Dr. Jain, can you unmute yourself? Oh, I muted her.
Is that better?
There. Yeah.
Can you hear me?
All right. Yeah.
Woo! Okay, so I think you guys were just talking about cystograms. Was the last little thing. So yeah, for cystograms, you have to know that there's no urethral injury, obviously, first. So you're looking for the bladder injury. And then once you do that, these are all bedside procedures where you fill up about 300 cc's of your favorite contrast, and then you inject it into the bladder. When you tell radiology to come, you have to tell them to come with 4 plates. 4. As you can see, 1, 2, 3, 4 plates. Right? So you do one with the bladder empty, nothing there. You do one AP film once you've injected, and then you have to do another oblique, right? Because you can't see if there is a leak. If there's a posterior leak, you won't see it on an AP film. And then you have to do another one after you've emptied the bladder. So then you empty all that junk out, and then you take another picture to make sure that it all in fact came out and that it didn't leak anywhere. I don't know if Dr. Silverberg just said all that, and if he did, I suppose I just reinforced it. Can you guys hear me? Hello?
Yeah, I'm here.
Who's there?
Everybody's here. So I mean, I think that was really good. Does anybody? So you have to do this.
And then.
Or the urethrogram. So the question that oh.
Yeah, questions.
Great. So go ahead. So you got to do the urethrogram. So the question is, do you have to do the urethrogram first and then do the cystogram after that? You can't do the cystogram first, right?
Correct, because obviously you want to make sure that you have a clean urethra before you can get to the bladder.
Dr. Hassel?
So when we're saying the 300 cc's or 400 cc's, are we just taking one vial and mixing it with 300 cc's, or is it multiple vials? Like, what's the exact concentration we need if we're doing X-ray, if we're doing portable?
So Dr. Hassel's question is, what's the concentration or the ratio that we should be mixing here for the contrast?
Yeah, so if you're doing just the rug, then you can take, again, your contrast of choice, gastrographin or barium. Barium's a little bit nicer because you can use less of the barium because it's so concentrated, and then dilute that in 50 cc's of normal saline, basically. And then if you're doing the cystogram, then you dilute that in 300 cc's. Then you use unconcentrated because you want to see any subtle tears. So you don't actually dilute that, and you have the X-ray guys come up with like 3 vials so that you get 300 cc's of fluid.
I think it depends if you're shooting films or looking at the CT. If you're using a CT, then we use 30%. That's what we normally do, right? We put 30 cc's in a liter. If you're shooting a film, I would go more concentrated. You guys remember when you shoot like egg placement tubes? You want to use a little more concentrated stuff that doesn't show up well on a pink film. I think on CT you can use less concentrated stuff. I would use 50-50.
Dr. Baronez's comment?
I mean, I think the reality for most of these patients is you may study their urethra and they're getting scans anyway, and probably going to just get. You remember the last time I just did cystogram with plain film?
Yeah, I agree. I was always
didn't get a CT. I think that's pretty infrequent. And the other thing is, many people will just do retrograde urethograms just for bad film infection. You could say the indication is they didn't void, but what trauma patients void serious trauma? I mean, if they've got an open book fracture or a bad straddle injury, they probably need a retrograde.
Can you just talk about the timing of that? Like, a person with an open book or severe pelvic fracture has a lot of other things going on, right? They're like, the trauma team's there, they want a pan scan, like, there's all kinds of things going on. When do you go go and walk to radiology, get the contrast, and like do that before they scan, like obviously after their vitals are stabilized, but like when obviously not like, oh, they're crashing, let me do it.
So the question here was the timing of these studies in a polytrauma critically ill patient. When are we doing the urethrogram?
Sometimes in these multi-trauma patients, a fractured urethra or injured urethra is a secondary injury. So a lot of times these things are not done by the docs. They're done in situ after the XLAP, after the angiogram. So yeah, a lot of times you're not going to be CPC to be done. It's going to be done as that tertiary or survey.
You're not going to let a guy with a pelvic fracture bleed out because pelvis leaving your urethra.
That's why you don't see urology very often in our family.
I think ideally, you should see the foot, you can see the physical exam findings, and then do your urethrogram as quick as possible, and then put the Foley in, and then send the CAT scan. That's the ideal way to do it. This way the Foley goes in, and you can do the cystogram when you're doing it. So that's the ideal way.
You're not always going to see that a lot.
Yeah, if you don't know it's there, then you don't know it's there.
Oh, she left. Oh, maybe she's back. That's great. How many people have done these? How many people have done this procedure? So, relatively rare. I got to do it with Dr. Marndale. I'm not a trauma patient, but a gentleman who was super embarrassed that had intercourse and thought he fractured his penis, and we were assessing then. But it was an opportunity to do it, and radiology was going to do it, and I went upstairs and did it. So I'd recommend going for it if you have the opportunity, because it's a relatively rare procedure.
We don't see much GU trauma, but it's good to go over it.
Funny story to make people feel better about all those stupid mistakes. Okay, when I was an intern, we did one. We used to have the pathway with gastrograph, and not the gastrograph, and gastrograph, and there was a styrofoam cup, and we did a styrofoam cup and injected it, and the first time you with that. Yeah, why? That's what gastrograph. Not sterile.
I try to leave names out of these stories.
Where do you find they already mixed the gastro with the water? Where do you find concentrated gastro?
In the cabinet in radiology.
In the CT scanner?
In the cabinet above, like the far
Just ask the techs.
Final questions?
Final questions, Rusa? All right, great. So that's it. I'm going to try to end this hangout. This is probably going to be available online if I can figure it out. Thank you for coming, Dr. Jain, and joining us.
Hey, thanks. Bye.